Okay, good afternoon, everyone. Yate, welcome and thank you for joining our webinar today. We're so excited to have you all here. My name is Donald Chi. I am Dinesh from the Navajo Nation. My clans are Tachitni, Ashihan, Kinlachitni, and Tabaha, originally from Red Valley, Arizona. I am the program coordinator for the National Native HIV Network under the Community Health Education and Resiliency Program. Our parent agency is the Albuquerque Area Indian Health Board. I am coming to you from the ancestral homelands of the Diné Apache, Pueblo, and Ute people of the Southwest region of the U.S. On behalf of the network, we welcome you to today's webinar, Increasing Visibility with Resiliency, HIV Care for Long-Term Survivors. Before we begin, I'd like to give a quick overview of our National Native HIV Network, some of the things that we do here with the network, and also following that, I'll provide some housekeeping announcements. So the network was created in 2017. It's a community-led response to increase and organize a national voice and presence in the HIV movement from the American Indian, Alaska Native, and Native Hawaiian communities, with support from IHS and the Health and Human Services Office of the Secretary's Minority HIV AIDS Fund. Okay, my tongue got twisted there. We provide, at the network, we provide input and guidance to assist IHS and other agencies in efforts to reach high-risk American Indian, Alaska Native, and Native Hawaiian populations with HIV testing, prevention, and treatment. We build group capacity, provide assistance to support extensive community engagement strategies, dissemination of information at regional and national levels. Our comprehensive approach is rooted in our cultural values, teachings, and affection for our communities. So before we move on, this session will be recorded and it'll be made available to anyone who didn't attend. And also, if you want to review it again later, it'll be available on our website at www.nnhn.org. For as far as questions, you can drop questions in the chat box as we go through the presentations. We have 3 presenters today. Any questions that go unanswered, we can circle back around through email and provide those answers to you after this webinar. So today's presenters are Dr. Alethea Gabrielis from Gallup Indian Medical Center, Raymond Alejo from the Hawaii Health and Harm Reduction Center in Honolulu, Hawaii, and Lisa Tiger, consultant from Santa Fe, New Mexico. So we'll start with Dr. Gabrielis. She'll share her work on age-related conditions, medication, and HIV prevention in older adults. We're so grateful to have you here today, Gabrielis, to share your valuable information to give us a better understanding of HIV care from a medical perspective. Dr. Gabrielis is an infectious disease specialist at Gallup Indian Medical Center. She completed her internal medicine residency at the University of Pennsylvania and her infectious disease fellowship at the University of Utah. She has worked in HIV treatment and prevention on the Navajo Nation and in the Four Corners region since 2013. Welcome, Dr. Gabrielis. I'll hand over the screen sharing to you.
Thank you so much, and I'm so thrilled to be here. I'm going to share my screen. I have a brief PowerPoint presentation to share with you guys today. And let me get this into a slideshow. Great. Can everybody see that okay? Great. So thank you so much for the introduction. My name is Alethea Cabrales, and I'm coming to you today from Gallup, New Mexico. I'm an infectious disease specialist, and I work for Navajo Area IHS. And I've been, as Donald mentioned, I've been working on the Navajo Nation almost for 11 years now, with a few brief time when I worked in Salt Lake City and also in Santa Fe. And I'm really, really excited to present on this topic. This is something I'm really passionate about. My training before I did infectious disease fellowship was in internal medicine. And so internal medicine is medical care for medically complex adult patients. And so that doesn't necessarily always, medically complex doesn't necessarily always equal older adults, but it often does. And so I've always had a real love for working with elders in my clinic. And that's translated into my HIV clinic, as a lot of my patients are, fortunately these days, because we have such excellent treatments for HIV and great medical care. My patients are easily, living into their 80s or early 90s. And so it's been my absolute pleasure to get to work with those folks as they've gotten older. So this is something that's near and dear to my heart, and I think a great topic for the webinar today. Um, so first of all, a little bit of background. So what do we mean by when we talk about like an older adult living with HIV? So believe it or not, most of the literature about HIV and quote older adults is talking about age 50 and up. And sometimes when I read that, I'm like, really? 50 is an older adult? I don't know about you guys, but I feel like I'm only getting better with age. So sometimes I'm like, oh gosh, 50. But the reason that that cutoff point is kind of chosen to talk about this is that there's a lot of literature coming out about this now. And this is actually a really hot topic, as a lot of our patients with HIV get older, luckily are living long, healthy, happy lives and are getting older. And what they found is that around age 50 seems to be kind of like the inflection point where it seems like some of age-related conditions and geriatric conditions start to occur a little bit more frequently in people living with HIV than maybe in the general population. And some of these things maybe start to occur a little bit younger than we normally think of. And so that's why 50 is usually chosen and talked about when we're talking about older adults with HIV. Um, Part of the reason this is such a hot topic now is that in 2014, nearly half of all people that have HIV are now 50 and older. So this is actually no longer like an unusual thing in my HIV clinic, but this is actually becoming at least half of, or not the majority of our patients. And so this is something that, all providers that treat people with HIV are, learning a lot more about and becoming a lot more comfortable with, as most of our patients start to get older. Um, So, what do we mean by increase in age-related conditions? So, overall, while the majority of patients in my HIV clinic are overall, as I mentioned before, living very healthy, happy lives up into their, potentially 80s or 90s, when they do research studies and we, look closely at the numbers, it looks like people with HIV do appear to have slightly higher risk of certain conditions compared with the general population as they get older. And we think that there's a lot of research going into this right now about what the reasons for this are. We think that some of it may be due to chronic inflammation and immune activation from HIV. And so there seems to be an effect too of how long someone went with untreated HIV before they got diagnosed or before they started on treatment. And sometimes that seems to have some long-term effects on, our bodies that don't necessarily fully reverse with antiretroviral treatment. So a lot of it does reverse. We fortunately, if no matter what stage someone's diagnosed at nowadays, for the most part, I can, even if someone's immune system is very, very weak, they have very low CD4 count at the time of diagnosis, usually because the medications we have these days are so good, usually I can, fully reconstitute someone's immune system and they're not going to get HIV related serious infections or have to pass away from HIV. But it seems like if folks that went a long time before they were able to access treatment, or maybe a long time before being diagnosed, some of that inflammation, some of the effects on a cellular level that happen to the body don't ever completely go away. And so it seems like, so especially for long-term survivors who were diagnosed in a time period where they didn't have access to highly effective medications, potentially for many years after diagnosis, or we didn't use to start treatment for HIV on everyone immediately at the time of diagnosis in the past. People who have that situation may be still living with some effects at the cellular level that may sort of predispose to earlier onset of age-related conditions, or being a little bit more likely to get those conditions. The other thing that might be coming into play is some side effects of HIV treatments themselves. Um, we're fortunate these days that the medications we have are much less toxic than what we had in the past. But in my HIV clinic, there's a wide spectrum. I have some folks that were diagnosed, in the 80s or 90s. And so they were on some of those very toxic medications years ago and still may have some long-term effects of that. Some of my younger patients or people that were more recently diagnosed have only been on some of the newer medications. Luckily, those are much easier to take. They're overall much less toxic, but they do still have some effects on what we call our metabolic system. So they can have some effects related to, weight gain, cholesterol levels, diabetes, and so definitely, we have to take that into account as people are getting older and they've been on those medications for longer. And what are some of the metabolic effects of those medications on our bodies long term? And then also some traditional risk factors, like, I don't know exactly why this is the case, but in a lot of the research on age-related conditions in HIV, they've often found that alcohol and tobacco use seems to be a little bit more common in people with HIV than in the general population. And we know that alcohol and tobacco use also increases the risk of cancers and cardiovascular disease and some other age-related conditions. And so maybe some of it is related to that as well too, which in a way is a great thing to find out about because those are very modifiable risk factors, right? Like we can change whether or not we use tobacco products or smoke cigarettes. And so, knowing what the impact of those things are and those things that we can actually change is really good to be aware of too. So I'm just going to go through a few of these different conditions that are things that like as we age with HIV that our, healthcare providers are looking out for. And then also as patients, it's really good to be aware of so that, we can advocate for ourselves too. So one big thing is heart disease. So heart disease is one of the number one causes of death worldwide, and something that continues to get more common as worldwide we start to see higher numbers of things like diabetes and obesity and other health factors that are related to increasing our risk for cardiovascular disease. And so the research on how HIV plays a role in heart disease is really interesting. So, there was a study, one of the biggest studies on this was done by the VA health system. And so they looked at, 80,000 veterans in the US who have HIV and found that even after they adjusted for every other risk factor, like, whether that person smoked, what their cholesterol level was, whether their parents had heart disease, they found that HIV was what we call an independent risk factor for having a high risk of heart attack. So it looks like that's kind of what we're dealing with, what we're stuck with. Again, as I mentioned on the previous slide, there could be a lot of different things playing into that, why that's happening. But what can we do to decrease our risk? So, a big thing is there are a lot of modifiable things that play into our risk for cardiovascular disease. And those are things like our diet. So, eating a healthy diet, avoiding things like saturated fat, really processed foods can really help reduce our risk of cardiovascular disease. Exercise. So there's a lot of evidence that getting at least 90 minutes of vigorous exercise a week, however you do that, maybe that's like 10 minutes every day, maybe that's an hour-long class, that you go to once or twice a week. That seems to really decrease our risk of cardiovascular disease too. Weight loss, so obesity, being overweight or being obese really increases our risk. And so, talking with your healthcare provider about this can be a really sensitive topic, but what would be, sort of the ideal weight for me based on how tall I am, and what are things we could do to sort of, try to get there? And maybe there's not an ideal weight for every person. Body mass index is, there's a lot of things that play a role in that, but talking with your provider about that and strategies to, improve overall health are a really good idea. And then also smoking cessation. So tobacco, cigarette use really increases the risk of cardiovascular disease. That's very modifiable. These days, pretty much, I think everyone that works in, HIV clinics or primary care clinics is well trained on how to help people stop smoking. And there are a variety of different things. There are, medications that can help people. There are behavioral interventions. Here in New Mexico, we have this New Mexico Quit line where you can call, 24 hours for free and someone can talk to you. So there's a lot of different things that your healthcare team can help you with. If you're struggling with quitting smoking, you don't have to do it alone. And then the other thing that is sort of a new thing, and this actually was a new guideline that came out about a week and a half ago in the Department of Health and Human Services HIV guidelines, which are what we as HIV healthcare providers read and kind of follow as a standard for healthcare. But there was a guideline that came out really talking about the role of cholesterol medication, specifically a class of medication called statins, and really recommending that these be offered, more broadly to people living with HIV. So they recommended that, starting at age 40, we, sort of calculate what somebody's risk of stroke or heart attack might be over the next 10 years. And we have a lower threshold to offer those medications to people because we know that HIV alone is an independent risk factor for cardiovascular disease. Um, so, it might be next time you go for an appointment, it may have been that your doctors kind of talked to you about your cholesterol levels before and said, oh, they're not that bad. And, not the point where we'd recommend medication. But with this new guideline coming out, it might be time to kind of readdress that. And maybe, the cholesterol levels aren't that bad, but maybe based on your overall risk and also now knowing that HIV is an independent risk factor, maybe that is a good idea for you for your health. It's going to be a little different for every person, but definitely something to be aware of and to think about. Um, so another thing that gets more common as we get older is cancer, unfortunately. And this has been an area that people have been really interested in for a long time. And, we used to think that HIV globally increased the risk of all cancers potentially. Definitely in the era before highly active antiretroviral therapy, there were certain HIV-related cancers that were much, much more common in people with HIV than in the general population. Um, these days in 2024, the more modern studies have really only shown a link between HIV and two specific types of cancer. One is lung cancer and one is anal cancer. And um, the research is continuing to show, even, kind of in the modern era of treatment, that these two types of cancer seem to occur at younger ages in people with HIV. Anal cancer kind of makes sense because anal cancer is caused by a virus called HPV or human papillomavirus. Human papillomavirus is extremely common. So it's estimated that about 90% of adults in the United States will get human papillomavirus at some point in their life. So pretty much all of us get it. It is sexually transmitted, but it's very, very easy for it to transmit. It doesn't, it can transmit even through sexual contact that's, not what we would necessarily consider like intercourse or insertive. It's very, very transmissible. And condoms don't necessarily protect against it. So pretty much anyone who's ever been sexually active at any point of any type in their life usually has come into contact with human papillomavirus. And so because of that, about 20 years ago, a vaccine came out to protect against that. And so that vaccine is actually now given to boys and girls when they turn 9 years old in pediatric clinic. So in the future, we won't really have to worry about HPV causing cancers like anal cancer. It also causes cervical cancer and head and neck cancers. But for those of us that are older and weren't, 9 years old 20 years ago, we didn't have the chance to get that vaccine. And so we are at risk for this because we've been exposed to this virus. Often we're infected with this virus. And fortunately, in the majority of the time, it doesn't cause issues and doesn't cause cancer. But it can kind of get into our cells and cause some changes that can lead to precancers or cancers down the road. And one of those that seems to be particularly associated with HIV is anal cancer. So, anal cancer screening is recommended nowadays for transgender women and men who have sex with men who have HIV, as well as cisgender women who have a history of HPV-related cervical disease. So, that would be for women who've had a cervical pap smear, like their women's health exam, and they've tested positive for HPV or there's been an issue. It would be recommended to get screened for anal cancer as well too. And so that's also kind of something, if you were, probably your clinic has already talked to you about this if you're in one of those groups that's higher risk. But if they haven't, maybe bring that up next time and say, hey, I heard about this thing called an anal pap smear and I've never had one. Would that be recommended for me? And just kind of knowing that, anal cancer is something that's higher risk and knowing about how you can get screened and protect yourself. The other thing is lung cancer. And so lung cancer is a lot more unclear why lung cancer would occur at younger ages in people with HIV or be more common. We haven't really teased out, what might be causing that. But the good news is that there is also screening you can do for lung cancer, believe it or not. Um, Lung cancer is much more common in people that have a smoking history. And so it's recommended that if people smoked at least 20 pack years in their life, and so that would be like one pack a day for 20 years or half a pack a day for 40 years, that they get what's called a low dose CT scan once a year to look for lung cancer. And that would apply even if you quit in the past. So that's another thing to be aware of too. If you've smoked in the past or currently smoke, talking to your doctor about that. Sometimes doctors will forget about this, especially if you don't smoke anymore and you quit. But it's just good to be aware of too, because there is something you can do if you're high risk for lung cancer because you have HIV and you smoke currently or smoked in the past. And then talking a little bit too about menopause and cervical cancer. So, menopause also may occur earlier in people with HIV, and symptoms of menopause seem to be a little bit more common. And so, symptoms of menopause, this has gone kind of back and forth over the years. Years ago, it used to be very common if people were having symptoms around menopause, like mood swings, hot flashes, night sweats. We used to use what was called hormone replacement therapy to kind of help with some of those symptoms. Um, at that time period, it seems like we may have been treating people for a little bit too long or maybe overusing those medications. And then we learned about some side effects related to those. And it swung back the other way where we pretty much stopped using hormone replacement therapy for anyone. And what we've now realized is that that maybe was a little bit of a mistake or an overreaction. So there are certain situations and for shorter periods of time right around menopause where those treatments actually can be safe and can be really helpful. So that's another thing to know about too. If you're, starting to go through menopause or having perimenopausal symptoms, there are definitely things that your healthcare team can do to help you with that. And it may happen a little younger, be a little more severe with HIV. So good to be aware of. Um, the other thing that's good to be aware of too is that cervical cancer screening, which is also related to that virus, HPV or human papillomavirus we were talking about before that causes anal cancer. It also causes cervical cancer. And so it's recommended that Pap smears and women's health exams actually continue for life in people that have HIV rather than stopping at age 65, which is recommended for the general population. So that's a good thing to be aware of, especially if maybe you go to a women's health clinic or an OBGYN clinic for that, that's separate from your HIV clinic. Maybe sort of reminding them that, oh, I have HIV. So I'm actually not going to stop at age 65. I'm going to continue with my cervical pap smears and women's health screenings. Um, the other thing that can happen sometimes as we age with HIV is that we can start to be on more medications. So sometimes, as we get older, we're now on our cholesterol medicine and our high blood pressure medicine, and so we're on a lot more than maybe just our antiretroviral therapy. And so there was a big study in Swiss HIV cohort study that came out in 2010 that showed that adults 50 and older were, more likely to be on more medications. And so it was more likely for them to have medications that interacted with each other. And so that can be really important, especially certain HIV medications have a lot of what we call drug-drug interactions, meaning that they don't necessarily get along well with all other medications. And so especially as we get older and maybe we're on more medications, maybe we're seeing more specialists. So we have like more doctors, more members of our healthcare team that maybe aren't in the same clinic, maybe aren't all talking to each other necessarily. It's really important to let your HIV healthcare team know about any new medications you're going to start. Even herbal and over-the-counter medications sometimes can interfere with HIV medications. So as we start to add on more things like that as we get older, it's really good just to make sure we're keeping everyone in our HIV clinic in the loop and making sure we don't start a new medication that might have an interaction with HIV medication. And then also as we get older, rates of things that are called geriatric syndromes can start to increase. So these can be things like falls or functional impairment or disability. And studies have also shown that this might happen at relatively younger ages in adults with HIV compared with the general population. One thing playing into this is that bone health can be a really important topic in HIV. So there was a drug that was we used for many years called tenofovir, and this was the older version of tenofovir. So we actually have a newer version we use now, which is abbreviated as TAF, tenofovir alafenamide fumarate. We used to use this older version called tenofovir diproxyl fumarate in the past, and many people who've had HIV, for more than 5 to 10 years, were on this medication at some point. And this medication was very effective. It was really helpful, but one of the side effects of it is that it can decrease the density of our bones and it can have a negative impact on bone health. And so osteoporosis, which is the thinning of the bones, is more common, especially in people who took that specific antiviral drug in the past. And so it's recommended that people with HIV who are 50 and over, for men and for women, that they get these things called DEXA scans, which are bone density scans. And a DEXA scan is a really easy test. So I put a picture of the machine in here because sometimes I have patients that are a little bit like, what is this test exactly? And so you know, you kind of lie on this, and it basically is taking something similar to an X-ray of the hips and the spine, and measuring kind of how thick or thin the bones are. And then that can give your medical team an idea of whether you may have some thinning of the bones. And if that's the case, there are some things we can do in terms of looking at vitamin D and calcium levels and maybe increasing those, increasing exercise. And sometimes if it's particularly severe, there are special medications for that as well too. But especially as we get older and a little bit more likely to have falls or more frailty, it's really important to be conscious of bone health to prevent things like hip fractures and wrist fractures. And then what about HIV prevention? So people over the age of 50 are also still getting HIV too. So, you know, in 2019, a little bit over 10% of new infections were actually in people ages 55 and up. So it's really important for us, you know, not to forget about, you know, people in their 50s and 60s in terms of preventing HIV and doing HIV health education. And studies have the other reason we really want to sort of either prevent HIV or rapidly diagnose and treat it in older adults is that there have been studies that show that, you know, when an older adult gets HIV, even if you start successful treatment and someone becomes virologically suppressed, the immune recovery is less robust the older the person is when they got HIV. So we seem to have less reserve as we get older with our CD4 cells, and we don't recover quite as well when we're diagnosed when we're older. So that really has highlighted the importance of diagnosis and treatment of HIV earlier in older adults, as well as prevention. Um, HIV pre-exposure prophylaxis, or PrEP, which a lot of folks probably have heard of, hasn't actually been that well studied in older adults. It's most of the people in the PrEP studies were young, sexually active adults, and there weren't as many people, you know, age 50 and up that volunteered for the study. So we don't know quite as much about it. Some of the medicines that we use for PrEP can have some bone and kidney side effects, which you know is maybe not as relevant for someone that's 20 years old that's not going to be on it lifelong, but it might be a lot more relevant for someone in their 50s and 60s that's taking it. So there may be some alternative PrEP treatments that might be preferred, like the injectable PrEP, for instance, doesn't have bone or kidney side effects. And so maybe that might be a little bit preferable for an older adult patient. All right, and that's all that I have. I was trying to keep it short, and I tend to talk a lot, so I'm going to stop now and take any questions that might have come up for folks. And I do see a comment or a question in the chat about what about secondhand smoke. So yeah, that's a really good point. So second exposure to secondhand smoke doesn't seem to have quite as much health risk as people that themselves smoke, but it definitely makes it's a higher risk than no exposure to tobacco smoke at all. And that actually was part of the rationale for, you know, as laws changed in the United States over time. I mean, probably everybody remembers you used to be able to smoke in restaurants. There was like the smoking section, and you know, pretty much every bar like was covered in cigarette smoke, and you could smoke on airplanes. You know, there even though like clearly the air is circulating through the entire airplane, but there was like a smoking section. So some of the, you know, the ways that those laws got passed, basically not allowing that anymore, was that there is definitely, you know, real physical harm that could cause from secondhand smoke. And so it was felt it wasn't fair to the other people in the airplane or the restaurant, the bar to be exposed to that. And so, but yeah, luckily these days, I think unless you know, share a household with someone who smokes, you're less likely to be exposed to that out in public, but definitely that can be a risk. Um, and then someone also messaged asking about the message about injectable PrEP for older individuals. So yeah, I was going to say, so that's not across the board, and it really would depend on that person's, you know, health status and them talking with their provider about it. But there are now three types of medications we use for PrEP. Two are pills and one's an injection. And one of the pills, which is contains that older type of tenofovir that I mentioned before, TDF. And so that may not be as desirable for someone in their 50s and 60s because of the bone and kidney issues. So they might be more interested in like the other pill, which contains the newer version of tenofovir. But that medication is only approved for men who have sex with men and transgender women. It's not known if it works as well in cisgender women. Or maybe they might want the injectable PrEP, which doesn't have any kidney or bone side effects. And then Kennedy Man asked, what is the oldest person that has been studied that's taking PrEP? That's a really good question. I have to go back to the PrEP studies and look at, they usually put the age range of the people who participate in the studies. And so I might be able to come up with that by looking at like what the top age range was. Um, but I'm not sure. I know that they've definitely skewed towards younger individuals in the PrEP studies, which is why like we often feel like we don't have like a lot of older individuals taking PrEP that have been studied, at least in the research setting.
Dr. Gabrielis, are we able to access those studies? Is there a
Yeah,
website that we can go to, or if you want to
yeah.
share that, email that to me, I can share it with the
Definitely. Or I can also put the link to some of those studies in the chat as well too.
great, thank you. There's another question from Darnell. Any additional common comorbidities?
I think those are the major ones that we know about. So it seems to be cardiovascular disease. So that's like stroke and heart attack. Cancer, but it's specifically those two cancers, anal cancer and lung cancer. Um, and then just some of the issues related to falls around related to sort of bone health and bone density. Obviously, there could be other specific things that are specific to individual folks that, I've got some older patients or long-term survivors that took medications years ago that affected the nerves. And so they are living with what we call neuropathy, which is sort of painful long-term nerve damage. I have other patients who took medications years ago that affected their kidneys and things like that. But it's really going to be different for different people based on sort of when they were diagnosed, how long they've had HIV, and also what medications they took in the past, and then also just their individual health.
Okay, I see someone raising their hand. Um,
I think that's Savannah, Jean.
Yes, thank you for your presentation, Dr. Gabrielis. One of the things I wanted to mention was when we're talking about smoking, being mindful about distinguishing between commercial tobacco use and traditional tobacco use. I know that there's quite a bit of work being done by like the New Mexico Commercial Tobacco Coalition around like the messaging for that. So, as we think about giving education to our clients or our relatives, being mindful about distinguishing between those two different tobacco uses.
Yeah, that's a really excellent point. And yeah, I do talk with my patients. It very obviously, as you know, in the nomination, it's very common for people to use mouth tobacco or traditional tobacco. And yeah, that's really not what we're talking about when we talk about tobacco in these types. Like we're talking about cigarette smoking. So yeah, thank you so much for bringing that up.
Dr. Gabrielis, I have a question, a related question to traditional tobacco. I know that on the Navajo Nation, there's um, like the clinics on Navajo incorporate traditional healing. Um, can you talk a little bit about, the availability of that and how you all with working toward like balancing that, like traditional healing practices and Western medicine?
Yeah, absolutely. So yeah, on the Navajo Nation, I believe every IHS and 638 facility has in some places in Gallup Rhyme it's called the Office of Native Medicine. Some places it's called Traditional Medicine Department. Um, but within our electronic health system, we're able to place a consult to our traditional medicine practitioners and let them know, sort of what our patients interested in, and then they'll meet with patients and um, the services are different at every facility because obviously for individual like medicine men and medicine women, sort of what their specialty is or what ceremonies they can perform is going to be a little bit different. But they will do a consultation with the patient and then find out kind of what they're interested in, and then provide as much as they're able to, within the healthcare facility. So, most of our hospitals have hogans where a lot of consultations or ceremonies will take place. And then sometimes there are like additional ceremonies that are needed, et cetera, outside of that. And then they'll also kind of talk about a plan for that too. But yeah, I'm really happy that it's available pretty much every facility on the Navajo Nation, including here in Gallup.
Great, thank you. Any other questions? Okay, we'll have this recording available. If you have any questions following this webinar, you can email me any questions that you may have, and we'll get back to you on those. Okay, thank you so much, Dr. Gabrielis, for the presentation. There was lots of great information that you offered, and I look forward to working with you in the future. Say hello to Dr. Irilu in Gallup for us.
I will definitely. He's right next to me.
Cool.
Thank you, guys.
Okay, moving forward, next we have Raymond Alejo from the Hawaii Health and Harm Reduction Center in Honolulu, Hawaii. Raymond comes from the Alejo family on his father's Philippines side and the Angeles family on his mother's side from Nanakuli, Hawaii. Raymond was born in Waikiki, raised in Pearl City, and now lives in Wahiawa, Hawaii. Raymond Sal Alejo is an RN at Hawaii Health and Harm Reduction Center in Honolulu, Hawaii. Raymond has been a nurse since 1985. He got his training in Seattle and worked for Harborview Medical Center in Seattle, Washington, where he was trained in neurology and neurosurgery, acute and rehab nursing. He came back to Hawaii in 1998 to care for his grandmother, mother, and father. He became a nursing case manager at the Life Foundation in Honolulu and continued as a community health nurse and nurse case manager at Hawaii Health and Harm Reduction Center. Today, Raymond will speak on how he supports and advocates for services to address the needs for the aging population in Hawaii. He will talk about his program and how they work together, utilizing traditional and cultural knowledge to implement HIV care for our Native Hawaiian communities. Thank you, Raymond, for being here. It's nice to meet you, and I'm looking forward to hearing all the great work that you're doing on behalf of our Hawaiian relatives.
Mahalo, and thank you so much. And Dr. Gabrielis, that was a wonderful presentation. I learned a lot from that, and there's a lot of information that I can take back to our community. So I didn't have any slides prepared because I felt like we should just have a discussion about this. And I'm coming from the community health and care, the community health care perspective of HIV care. I'm also a long-term survivor along with being a nurse. I'm a long-term survivor and was diagnosed in 1985. And so it was kind of an interesting thing to have a dual role as a long-term survivor and yet a nurse too at the same time. When I first started doing HIV care, I didn't, during the time, I was just so like not wanting to learn anything because at that time, who cared? We were going to die in 2 years. They told us that. And so I thought, well, just, figure out a way to, live the last 2 years of your life and kill over. But, what is that? 40 years later, I'm here. So I'm very glad to be here, and I'm glad to be talking to you today. So when we talk about our elders and long-term survivors of HIV, in Hawaii, we have several terms that we call our elders. One of them is kupuna, and kupuna means what kupuna translates into is a never-ending spring. And in Hawaiian terms, our feeling about our kupuna is that they are a wealth of knowledge and a wealth of life, as water is life. It's a spring that never ends. So with that perspective in mind, that's where we come, or we address or we feel about our elders. The other term that we use is hulu makua, and hulu is to be esteemed. Hulu actually means feathers, but hulu also means esteem. Makua is parent. So we see our patients, we see our elders as a never-ending spring of life and information that are very esteemed. Dr. Grabelis, you really hit on a lot of things, because as we get older, we're so vulnerable as HIV, people living with HIV, to many diseases. And, for us long-term survivors, we also have to live with the fallout of those earlier medications like Crixivan, Zeret, DDI, more recently, tenofovir, TDF, abacavir, AZT, all those had they had a wonderful role. They saved lives, but at the same time, it also gave us some really debilitating at times side effects from them. And though we may have been, in our lives before HIV, we might have been predisposed to these, but those medications kind of, what they did was kind of accelerate our vulnerability to those disease processes. When I thought about the challenges that we have now, I thought about our age, and I thought about just our place in life. And, we're at that place where we're 50 above. And, at one time they were saying that, HIV also kind of accelerated our aging 10 years. So 50, I think, would be an appropriate place. But the knowledge that we have as far as HIV and people that work with HIV or living with HIV is not what the world has. And so, I thought about all the kind of things that we have, and I wanted to talk about later trying to access support services. But at this point, at 50 years old, now our roles have changed in our lives. Our roles have changed in our families, our traditional families. And sometimes we have to start caring for our elders. At the same time, as long-term survivors, and this started probably in our 20s and our 30s, that our support system in our community kind of died away, and because we didn't have those type of medications that could save them at the time, and we're kind of left on this earth, to kind of carry on this tradition and this time that we have as far as people living with HIV. So, I found that for myself, coming home and taking care of my my elders, both my grandmother, father, and my mother, it was kind of an interesting time, because I still was dealing with a lot of HIV issues. In 1998, I ended up in a hospital for a little while, and then I got better, and then I went on disability. And just that alone, going to disability, and then having my grandmother get sick, and me in our traditional roles, and it's it seems that in our roles, sometimes the mahu or the gay person in the family will end up being the caretaker of the family themselves. We're kind of the kahu or caretaker. And so we assume that role. And, how do we do that and negotiate our own health as far as surviving HIV? And I think it's getting a little bit easier just because we have a little bit, just because we have better meds to kind of help us through. But it was still a struggle at the time because, our medications we were still in that time of medications of TDF and Xerit and whatnot at that time. Um, and now that we're at this point now, at 50, a lot of us are starting to assume the role of elders in our family, which comes with a lot of responsibilities. Responsibilities like settling disputes in families between, now that we're in this role as being an elder, we're responsible for settling disputes in the family, making decisions during the death of an individual, how to kind of negotiate the rest of the family, how to keep them together. Just because now we're in that role and our elders are gone, we have to figure out ways to keep them together. And, a lot of times we're not trained that way. We kind of figure it out as we go along. Maintaining and passing on traditions that were given to you that you now have to give to our youth. And I think that too, in its sense, has such a big responsibility for us to kind of continue that, because HIV or not, we still need to kind of carry on that culture that we were given, that we live in. I'm a kumuhula, and um, I also am the kahu of my family, so it was a big responsibility to kind of pass on all these traditional chants, trying to remember it, especially if we have like that whole kind of memory loss and all those kind of things. I've kept these chants in my head for a long time, and now I had to disseminate it to my nieces and my nephews, and it was a little bit of a challenge. And I'm glad that I have my teacher to help me. He's still alive and he's here, so he can help me pass on these traditions that I've been given years ago. I wanted to also, kind of talk about how we relate to our patients, especially at that time of like 50s, in our 50s, especially when we're trying to get services established for our elders, which again are starting at 50. I noticed that from 40 on to 50 to 60, it's really a challenge to find support systems for our patients in our community, to be able to support themselves. From 60 and above, we can sort of access Medicare. SSDIs a little bit more is a little bit more attainable. All those kind of things are just a little bit more attainable. Over here, we can't get Meals on Wheels unless we're 60 and over. So, how do we accommodate somebody who's on disability and needing to like get food? Thank goodness we have a sister agency that will help us with housing, get them get them in a place where they can at least find a little bit of lodging, in the time being while they're looking to establish their housing. Um, Also at this time of life, sometimes we're put in a place where we're assuming the responsibility other of other family members. I talked about, having to take care of our elders, and even seeing them to their walk in life. But then also we're at this place and at this age where we're also at least partially sometimes taking care of children. And, at least for in a role of babysitting, or even being the caretakers and the parent of the child that's in our family. Those kind of things, take a take a toll, take time and energy. And at 50, trying to negotiate HIV and HIV care sometimes can be a challenge. And I see it a lot in our grandmas, our tutus, and our mothers, and our hanai. In Hawaii, we have what we call hanai. And hanai is to just it's not adoption, it's just that we take a child, or that we're given a child to take care of. And when we do that, a lot of people sometimes do it out of necessity, but many times do it because that's part of their family and they just come to live with you. And so trying to negotiate health and HIV along at being 50 and above, having a 2 or 4-year-old child is sometimes a little bit challenging for our community. I think one of the things I wanted to talk about too was, strategies on how we can support our patients and our community. And one of the things that we I have a group, and one of the things with this support group that we establish is that living with HIV is indeed a culture. We live according to certain behaviors. We have to do certain things to survive. So living with HIV became a culture for us in itself. So once we kind of started thinking about it that way, people started to form groups and started to look out for each other a little bit more. And I'll talk about the groups in a little while. But I thought, the people that work for AIDS service organizations, and also for, elderly type of service agencies, maybe might need to assume the responsibility of forming groups outside the agency, especially in outlying cities. I mean, over here, and how I discovered that was, the YNI range is 50, 60 miles away from Honolulu. And Honolulu is where we are located and have services. And how are we gonna ask our kupuna, or our elders, to get on the bus to travel 60 miles, 50 miles to get services in Honolulu? So what we started doing was started forming groups out in the outlying places. And this was where we established what we call the Ahaola, or the Court of Life. That's the name of our group. And there's certain things and certain roles for our elders in this group to kind of celebrate them and to include them in a lot of things in that group. For us, because we have so many, we have people that we had people that are coming from Samoa. We have a lot of people from the federal states of Micronesia. We have our local population, our native Hawaiian population, and we have Asiatic populations like the Filipinos, Chinese, our Korean, and our local Asian population as well. So for us, we practice different cultures and customs in our group, but the main focus is our mother culture, which is the Hawaiian culture itself. You know, a lot of times it's up to us to figure out how to kind of negotiate all these different cultures, and it's a little bit of a challenge, and it's also kind of nice to have all these cultures figure out and share things that um that that they have in their cultures with others too. So we started doing what we call the Ahaola, or the Court of Life support group. And in this support group, we have different protocols of our mother culture. The first thing we do is we pule, or prayer. And in this pule, we we uh we make it where whoever is doing the pule, whichever hulumakua or kupuna is doing the pule, they can pule to their god, but it's not it's not limited to any deity. It's the deity of the person who is praying, and it's their choice. We do a pule, and then we have what we call himia aina, which is we talk about the land that we're on. Since we are because in theory, or not in theory, but because a lot of times what we do as people in Hawaii is that we define ourselves as the land, as part of this land. Part of this land defines us, and that's in our definition. So to know about our surroundings, and to know about, like, say, for instance, the wind, the name of the winds, the name of the rains, um, the different things that Aina or land had shared historically. After we do that, we have kuka, which is to talk and discuss issues about our living, how we can improve our living, what issues that were brought up at what issues they've been experiencing is brought up, and we start to discuss that. Then we have what we call kamia'ai awakea, which is lunch. And after lunch, our group can break into several types of groups. The breakout groups is one of the groups that, or one of the things they can do is access our hulumakua, our elders, only to kind of figure out if they need to, if they need to have counseling from our elders, kind of, share wisdom, share experiences. Then we have a kahumalama, or nurse or case manager, that people can go to if they have issues with medications, or they're starting to experience medical problems. And then if they have any social work kind of things, they can also talk to myself, which is who is the nurse, or the case manager that's at the meeting. After that, we have a closing oli, which is a chant, and that wishes us well and that protects us throughout the time, throughout this journey. And that's the end of the meeting. We meet twice monthly. We meet on the second Friday and the fourth Friday. We have a meeting in Kaka'ako, and we meet on the beach. So, and it's open. It's nice, and just calming. So we're not in an office where it's we got to watch the time, and our support groups are about 4 hours long. So that's our ahaola, and the role of the role of our elders is to really just kind of lend wisdom, their experiences and what they experience as far as living with HIV, how they, we have let's see, we have three women and one man. And so they talk about how, raising children and what's been happening with raising their grandkids, and, just give guidance on that too as well. So I just wanted to kind of introduce that and talk about that, because this is a really significant role for our elders to be able to kind of decimate uh, uh, disseminate a lot of information on living with HIV, along with culture and cultural practices. So thank you.
Thank you, Raymond. I see a lot of people, everyone clapping for that presentation.
Oh, thank you.
Yeah, thank you for sharing. That's beautiful how you incorporate the Hawaiian cultural teachings into providing healing and support to um, folks living with, our relatives living with HIV. Okay, I love also that you're providing transportation to bring the group together along the beach. That just sounds really healing in itself. And Lisa commented, are you making the ride fun with playing bingo and things like that? And Kanani says, Mahalo Nui Pono. I'm hoping I'm pronouncing that correctly. Okay, in the interest of time, if you have any questions for Raymond, we'll hold that to the end. We'll move right along with our next presenter. Again, thank you, Raymond. Yeah. Okay, our next presenter is Lisa Lou Ella Tiger. She's an HIV and AIDS educator, motivational speaker, ambassador for the Davis Finney Foundation, and U equals U Indigenous Ambassador with Indian Health Services. Lisa was born in 1965. She is an enrolled tribal member of the Muskogee Nation and is of Creek, Seminole, Cherokee, and Irish descent. Lisa has been doing HIV education since her diagnosis in 1992. She has won awards for her work as an AIDS educator from the National Organization for Women and AMFAR. Lisa has had a lifelong love of fitness and believes vigorous daily exercise has slowed the progression of Parkinson's. Thank you, Lisa, for taking the time today to share your story. It was also very nice to meet you, and I love your incredible energy through our email conversations, and I'm looking forward to your presentation today.
Thank you. Yes, my name is Lisa Luella Tiger. I have been living with HIV since 1988. That's when I was dating the person that I was contracted the virus from. And immediately when I found out that I had HIV, it was actually kind of like, I mean, I know it's weird to say this, but kind of like a blessing to me, because I had just lost my brother who had been shot point blank between the eyes, and I didn't know how I could live without him. And I remember there was times when I was grieving his death, when I would like a thought, I would like something would make me like laugh or something, and then this little mean thought went through my head, and it said, "What are you laughing about? Your brother's dead." And I would like apologize and say, "I'm sorry, I forgot." So the grief of losing my brother was nothing. Testing HIV positive was nothing compared to the grief that I went through in losing my brother. And it actually gave me permission to say, I'm going to be happy again. For the rest of my life, I'm going to be happy. And I will be with my brother again someday, and it'll be sooner than I thought. I like everybody else who has HIV, and back in the 80s, we thought we had 2 years to live if we had AIDS. That was our life expectancy, was 2 years. I remember I went on to have a baby. I dated a guy from that's why I'm in Santa Fe now. He's a Pueblo Potter, but I started dating him. and we broke up because I wouldn't have sex with him. I was like celibate, you know, and I kind of had this attitude towards HIV. Was that's what got me into this mess. You know, I'll never have sex again. I just had that kind of attitude towards it. And plus, in the beginning, of course, I believed that nobody would want to have sex with me because I have HIV. But then I realized that there's some people out there that would still be willing to do that with me. And and for a long time I thought, I was suspicious of that. I'm still maybe kind of suspicious that I thought, oh, they already have HIV. They're trying to get me to have sex with them so they can blame me for giving it to them. So I was kind of just, I don't know, I'm kind of, but I've mostly lived a celibate life, and it seems like when I'm not sexually active that my spirit is freer, and I can be happier. So I live a happy life. I consider myself to be asexual, and I'm happy about the fact that I don't want or desire sexual activity. And I know this is a speech on, growing older with HIV. And, I keep thinking, like, if I do get a partner and they want to have sex with me, I think, oh, are you ever going to not want to, or don't you ever grow out of this thing? But anyway, so but I was able to have a child with HIV. I was an older person. I remember when the guy that I was talking about, we dated back in the 90s. And then 10 years later, we broke up because of alcohol. I didn't like that he drank. And I thought, I do presentations to people on reservations all across this country. And I talk about the evils of alcohol, the evils of alcoholism. And I would say, I can't, tell these people, tell these children in these presentations, the evils of alcoholism, and then date somebody who drinks. I felt like I would be a hypocrite. But anyway, I blame alcohol for a lot of bad things that's happened in my life. And and just like Dr. Gabrielis was talking about the alcohol, let's see, where did I write that? It said alcohol and tobacco use is a factor in lung cancer with people with HIV, is the tobacco use. Well, my mom was a smoker, and I hated the smell. I hated, I didn't like anything about it. So I call myself the first generation. My daughter, will be the second generation of non-smokers. I've never held a lit cigarette in my hand. A lit cigarette has never touched my lips. And so I'm very happy of the fact that I don't smoke cigarettes. I don't drink. I don't do any recreational drugs. I try to be as healthy and fit as I can be. And I really do believe that being out and open about HIV from the get-go, from the beginning, I remember some people, it seemed like they died of shame. They worked so hard to not allow people to know that they were diagnosed with HIV. This one woman who was infected by the same person that infected me, she came to our art gallery in Muskogee, Oklahoma. She came in and she said, she was just really frail, skin and bones. And you could tell that, they used to think you could tell by looking at somebody if you had HIV. But, and she had lost a lot of weight. But I just told her, I said, so she said, somebody said, what, stopped her at the Kmart, back when we had Kmarts. But they stopped her at the Kmart and they said, what is wrong? Why are you so skinny? And I say, and then she said, it's so awkward. And I really believe that shame, it puts such a heavy burden on you when you're ashamed of something, and I really believe that shame was killing a lot of us who have HIV. If you have to be ashamed of something, ashamed of the way you got it, or ashamed of who you are, these things, we got to release all that stuff and be who we are, as people. And I really believe you can only be healthy true, to your top healthiness, if you own what you are and what you, who you are and what you do, and not let anybody put that shame on you. Don't feel it yourself. Don't feel that guilt. It's just a heavy burden to be carrying around with you. And so anyway, when I went to my doctor and in 2003, and I said, what do you think about me trying for a pregnancy? And she said, yes, we must get you pregnant. And she and I thought, I was like what? This is weird. But I wasn't taking any of the AIDS drugs, because of the reasons that it was, a lot of the AIDS drugs was killing people back in the day. The AZT and the DDI, like I heard you mention, those drugs, they were what, and even my doctor admitted to me when I was big and pregnant with my daughter, he said, if Lisa would listen to me back when I was trying to get her on these AIDS drugs, she would not be the healthy person that you see here today. And so I pushed it off until 2003, when I was able to get myself pregnant through artificial insemination. I was able to get this baby the first time I tried, and I was able to carry her with only 20 T cells. I had no immune system whatsoever, 20 T cells. And it was the hardest time of my life because I got shingles, the HPV showed up in my body during that time. And, there's just all these different things that were, that I would often pray that I could make, make it through this pregnancy to give this child life, and then I could die. But once I got there and they pulled her out, the cesarean, they pulled her out and showed her to me, I got greedy and I thought, I'm going to raise this baby. I gave her life, and I was really sick. I was in the hospital for 3 weeks after I gave birth to her. And my fevers went up to 105.6. And, so I even had aphasia, brain damage from that high of a fever and whatever I was going through. But one day I just decided, I'm going to get better. I'm going to get healthier. And I got out of that bed and I started walking around the hospital, while I was in there. And I said, I've got to make myself better. And I want to raise this baby. I don't want to just give birth to her. I'm going to raise her. And now she's 20 years old. She's in her first year at Stanford. She got into Stanford, and she's just a beautiful child. She's actually here on spring break. Not here, they're out roaming around New Mexico. But she brought 6 of her Stanford college buddies home for spring break. I've always told her that my home is open to any of her friends. She doesn't even have to ask me, that they're always welcome. Anybody that loves my daughter, I love them, and they're welcome to come stay with me in my home in Santa Fe. And I'm just, it's been hard, with that empty nest syndrome, when your kids go out to college and you're just so close with your baby. And then I was fortunate to, in 1999, I went from HIV to AIDS in December of, my T cell count fell below 200 in 1999. And I was also diagnosed with Parkinson's disease. My doctor was thinking, well, it must be age related, get on these AIDS drugs, and maybe it'll go away. But it was completely different. I said, no, my sister's going through the same thing and she doesn't have HIV. And so, I've been battling with HIV for all these years, but I really, truly believe that my commitment to exercise, and I exercise every single day. And I like to this year in 2024, I've already logged in 37 miles, I think 837 miles as of yesterday. And I like I said, I always tell people, when these legs work, I use them, because with Parkinson's, I can't walk all the time. I have to crawl. I use these crutches, to get around. But when these legs work, I use them. And I'm committed to staying as healthy as I possibly can. I know that the one thing that the thing I struggle with at this point, you know, I've had some depression because my daughter going off to college, but I decided I found out that there's a jujitsu studio like a half a mile from my house. And so I go there every single day and do jujitsu. And my goal now is to be a black belt by the time I'm 70. So I turned 59 this month, but I will be by 70. I'm planning on having a black belt in jujitsu. Yeah, so I try to stay strong and do what I can daily. I guess my biggest vice is sugar, and sugar is truly a drug. I've even heard people say that it's as bad as heroin, that like they say that mice in a laboratory, you know, they will go through electric shock to get to the sugar where they wouldn't to get to the heroin. You know, but sugar, they'll take the electric shock each time just to get some more sugar. And I know that it's bad. And at this point in my disease with Parkinson's, actually, Parkinson's has actually helped me with my HIV, because I would forget to take the HIV medicine every day. If it weren't for Parkinson's, my body shuts down and I'm not able to walk anymore unless I take that pill. And so I keep all my medications in a little bottle like this. And this is what I have with me every day. And it has all my Parkinson's meds, any vitamins I want to take. Oh, and if you can believe it, as much as I exercise, and that's what I was interested in, Dr. Gabrielis, when she said stroke and HIV, you know, have some kind of, I want to talk more about that, because as much as I exercise, I had a stroke in June of last year, June 2023. I was lucky my daughter noticed it. She noticed that the left side of my face was just kind of, different. And so she called the ambulance, and they life flighted me to Albuquerque, and they did a thrombectomy where they come up through here and they pulled that blood clot out of my brain. I felt it go through too. But they pulled that blood clot out of my brain. And I'm thinking, how is in good a shape as I'm in, how do I get a stroke? Well, they did all kinds of testing, and the day of the stroke, a doctor came and evaluated me, and he said, there's no way that I would have believed, if I hadn't been there myself and saw it for myself, that you had had a stroke today, because I was doing that well after having the stroke. And then come to find out, I have had a hole in my heart since I was born. I guess most people, they're born with one, but then it closes off. And those of us who didn't, I guess that the hole in the heart the clot must have passed through and then gone straight to my brain. And I was just fortunate. My daughter saved my life by me having her and giving birth to her, because I was too stubborn. Wasn't going to take the AIDS drugs until I had to. Well, I started taking the AIDS drugs for my daughter, because I wanted it, it's a 15 to 30% chance that a woman passes this virus on to her child if she has HIV, but it reduces it to less than 1% chance that she's going to get it. If I take the drugs, it reduces my viral load to nothing, where undetectable. And so I was able to give birth to that wonderful, amazing girl. She saved my life then, and she saved my life last June when she got me to the hospital in time. And in December, they plugged up that hole, and that's so weird. They go in there and do the crazy surgery like that, and they don't want to see you for 6 months. So, so but in the meantime, I'm exercising at a level that, with the jujitsu, it is hard work. and I just love it. So I'm gonna try to, for the rest of my life, make the most out of every single day that I have. What else is there to do? Besides just try to make your life better. And if I could just get this, what do they call it, a monkey on your back, that sugar bug, I liked pie, and I like, there's a time that I quit, on July 29th, I quit for for several months, quit sugar. I thought I was gonna get all these amazing benefits from it. But I said, oh, I have nothing to look forward to. I was all angry, but but I don't know. It's bad, but I'm just so glad that I quit drinking back when I did, because, our addictions, they're powerful, whatever they might be. I'm just, and we got to be understanding with people. It's not their fault that they're addicted to whatever it might be, drugs, alcohol, sex, there's so many different addictions. And but we got to decide what's best and healthiest for ourselves, and how do we want to live our lives. And I just keep trying to, to eat mostly a diet full of vegetables and fruit, and try to, my medicine won't work with my Parkinson's meds won't work unless I eat stuff that the Parkinson's medicine likes. So it should, it doesn't like sugar, it doesn't like dairy, it doesn't like wheat, or like Dr. Gabriella said, the processed foods are really bad. They're really hard on our systems, but that's what we eat. That's what's fast, that's what's easy, that's what tastes good, and that's what we look forward to. And so I think a really hard place is to fighting these things that are not good for us, that we continue to keep doing, because that's what makes us feel good temporarily for the moment. So I guess if anybody has any questions, I think that that's a place where I can stop for now.
Hey, thank you so much, Lisa, for sharing your story. It was very powerful.
Oh, thank you.
And congratulations on your daughter going to Stanford. Wow. We have a couple of comments. Savannah says she's going to have to take up jujitsu because her baby's going off to college soon.
Oh, yeah. Yeah.
And
sure.
Carmen absolutely loves you, Lisa. She says you are a beautiful, strong Indigenous woman. Many blessings to you and your daughter.
Thank you so much.
And Carlos Thomas says, Lisa, I need an update on the hole in your yard.
Oh, yeah.
Sounds like you two know each other.
Yeah, the hole in my yard. When I was taking a class on the tribes down in South America, the Mayans, and these are different tribes, and they were diggers. They dug like way down deep, and they had different levels. Like they lived here, and then they had different levels, and there's one level where they keep their dead, and they can go and check on them, if they want at any time. And I thought, wow, that is so cool. So I just started digging a hole in my backyard, and it started out just, I have pictures when I just have my foot stuck in that hole, and then I put my grandchild in the hole. and put a little, like a one of those racks that you get in the oven, put it on him like he was captured in there. And the kids always have so much fun in the hole. But I dug that hole. It was like 10 foot deep at one time, and I could get down there and sit around and I just loved it, just being around in the dirt hole. But then everybody said that thing's gonna collapse on you. And then once I had a dream that it did come in on me, so I bricked it up, and now it's now it's 6 foot deep now, and it has different levels where you can go and sit. And it's like my idea, like someday we'll block it off and we'll have a sweat there, put the rocks down in the middle, or so sometimes I try to go fill it up with water and it won't hold water, so the earth just takes it away. So I feel like it's a place where you can go and sit, and you can, if you have something that's weighing heavy on you, give it to the hole, and the hole will take it and go, go away with it. And so I call it the whole heart hole, the whole WHOLE, and then it's shaped like a heart. It somehow, I didn't mean for it to be like that, but when I bricked it in and put the rocks around it, it's like a heart. It's shaped like a heart. So I call it my whole heart hole. And a lot of people, when they come here, they love to go out there and sit in it, and they say, I want to make me a hole. I want to dig a hole. And so it's a place to just hang out and make yourself happy.
Awesome. There's one other question, then we also have a couple of comments to both you and Raymond. Darnell is asking, what other things motivate you on your journey?
Motivate me on my journey? Well, of course, my daughter, and like I remember back, there was a time when they did the poly chain reaction test, the PCP test. Is that what it's called? Wait, what's it? PCR, poly chain. And somebody called me and they said, oh, hey, Lisa, you need to ask your doctor if they've given you this kind of test, because you might not have HIV. And I remember going, oh, you can't take my HIV away, because I was thinking that, this is my way out of a painful life. I lost my dad to violence. He was shot in the head when he was only 26 years old, and he was a really talented, famous artist. And then his son, my brother, who's only 2 weeks old when my dad was shot and killed in 1967, he was murdered at the age of 22. And then, here I'm thinking, I'm going to get out of this life without any more pain and suffering, because the next funeral I go to, it'll be mine, and I can handle that. I can be the next one to die. I can do that. But little did I know, I had a lot of, when we live, we lose people that we love. And all the people in the beginning who lost all their, best friends, this whole community, it was, of all the people we've lost to AIDS, it's devastating. I know that you can think of people that would be here otherwise. So it's a devastating process. But I raised some kids from a reservation up north. I was I was doing AIDS education on there, and these little kids started following me around and asking me if I was their mom. And so I thought, who are these kids? There's 4 of them, and so they said, oh, it's so sad. We can't find a place for them. I was staying at a youth shelter because there was no. The casino didn't have a hotel at that time back then. And so I was staying at a youth shelter, and they said the children's village was full. So they put them in this youth shelter where I was staying while I was doing my AIDS education around the place. And then I thought, well, what's going to happen to, they said that, it was either here or the jail that these kids would have to stay. So they were 4 of them, 2 boys, 2 girls. And I went and I just asked the tribe, I said, hey, I want these kids, and then they gave me temporary custody, and that was back in that was February, that was February 1996. The day, it was actually February 13th. And the next day, on my mom's birthday, I flew her home 4 little grandchildren. They were ages 3, 5, 6, and 7. And, my plan was, have these kids, raise these kids, be happily ever after. But my little girl, my oldest girl, she was stabbed to death by her boyfriend on August 13th, 2007. And that was 40 years to the day that my dad was shot in the head and died. And so, I don't know. I think these dates and all this stuff that when things happen, they mean something. It might seem, like a coincidence or something, but I think these things are long set out long before. And instead of, but she had a child, and I'm a part of the child's life now. And so we, life, all these horrible things happen, but life goes on, and we can make a difference in this world if we even if we're more compassionate of what other people are going through and what they've been through. I think the thing that Parkinson's has taught me is really humility, you know. I mean, how can I think I'm better than anybody else when I'm crawling to the bathroom because my legs won't work because of this disease? Back when I was younger, you know, I had this attitude, you know, like, you know, I just had an attitude, you know, by being young. And you know, yeah, I have HIV, and they used to accuse me of glamorizing AIDS. You know, and but AIDS is, I mean, I remember that I would not listen to what people in the end stages of AIDS would go through, because that was too scary. You know, I didn't want to look at that part of it. And I don't know if that was because I was just didn't want to face that part of it. But you know, Wilma Mankiller, she was the chief of the Cherokee Nation. She called me up one time, and she was a friend of my sister's, and she said, "Lisa, I've been dealt with many health challenges in my life, and they always come up with something. They say, you know, this disease or and they said the same will be true with AIDS." I didn't believe her when she said that. I thought, no, you know, I'm sure that AIDS is, you know, they won't find something, but they did, and here we are. You know, so if we're here, we might as well try to make the best of it.
Thank you, Lisa. Again, we are at 2:33. I see a lot of messages thanking you and Raymond and Alethea or Dr. Cabrales for the time here. I think Raymond might have dropped off, but Carmen says, thank you, Raymond. Many blessings to you and your family. Carlos, let's see. Carlos says, thank you for sharing your story with us, Lisa. You have been and are always a positive light in our community. Tyrone says, hi, Raymond. Great to see you. Hope you are doing well. Alethea had to run back to her clinics, but if you have any questions for Alethea, please send them to me and I can forward them to Alethea, or I can send out their email addresses. Kunani has another meeting. You folks have an amazing day. Mahalo for the knowledge passed on today. Thank you, everyone. I'm so sad to go, but I have another meeting to attend. Raymond had to do wound care on a patient. So, but yeah, so that concludes our webinar for today. Again, please visit our website, www.nnhn.org. Become a member, get our monthly ribbon song newsletter. We have announcements on there of upcoming webinars, conferences, and we have a lot of HIV resources there as well. So we do these every other month. So our next webinar will be in May, and that tentatively is, while we're working on the date right now, it will be on HIV and housing. So thank you again, everyone, for joining us, and you all have a wonderful rest of today and a great weekend. Yeah, that on it.
I don't know. I can't hear you now. Oh, you've got.
Okay, sorry. I had it. Let me stop this recording.
Okay.
So